Uh, this is Congressman Mark Takano again, and I am now, this time, with Dr. Geoffrey Leung, who is the person at the Riverside County, the Riverside University Health Systems that oversee all of the clinics. I'm actually in a particular clinic right this very moment at the Rubidoux Family Healthcare Center here in Rubidoux. And we're in one of the exam rooms, and you can see Dr. Leung he looks like a doctor. He's dressed in a doctor's lab coat or a clinic coat. And there's an exam table right here that I'm touching, and then all of the medical equipment you can see behind me. And Dr. Leung, thank you for joining me and helping my constituents understand what's at stake in some of the legislation that's moving through the Congress. And the work that you do here at this clinic and what you do throughout the county. But so tell us a little about the numbers of people you see here at the county, what are called ambulatory centers, and that's just a fancy word for a clinic that you can walk into as opposed to go all the way to the county hospital. So there's the county hospital, and then there are centers like this Rubidoux Family Healthcare Center that people, it's kind of in the neighborhood you can go to, and it's called an ambulatory center, right? So tell me more about what you do.
So first of all, I serve as our medical director, and I help support all of our physicians and nurse practitioners and physician assistants in our clinics. We do have clinics both at our medical center in Moreno Valley as well as throughout the community. And we have 10 community-based clinics. In those clinics, we see over 100,000 patient visits each year. And then at the medical center clinics, we see another 100,000 patient visits each year.
Wow, so 100,000 at the clinics, 100,000 people at the hospital itself.
Right.
So that's a lot of people. And we're not talking about, so overwhelmingly the people you see are people who are insured through Medi-Cal,
right,
or also known as Medicaid, but in California we call it Medi-Cal.
That's right. So about 70% of our patients have Medi-Cal as their form of insurance. And that's a big increase from before the Affordable Care Act, where probably only a quarter or a third of our patients had Medi-Cal.
Wow. So before the Affordable Care Act, most of your patients that came in didn't have payers.
Right. Before the Affordable Care Act, most of our patients did not have any insurance.
Wow, that's incredible to know. Now, this, we had a recession going into 2008, a very severe one. It hit our county especially hard. Construction industry just shut down pretty much. And within a couple of years, or by 2009, 2010, the Affordable Care Act comes into existence. Earlier this morning, I was talking to Dr. Gilbert over at the Inland Empire Health Plan, and he told me that uninsured rates went down. There used to be about over 20% of Riverside County residents, or the Inland Empire residents, would be uninsured, and it's now down to 6 or 7%. So that kind of matches your experience here, that most of the patients that you see now, of your total patient load coming into an ambulatory center like this, they actually have insurance now.
Absolutely. So most of our patients now have insurance, and the things that people worry about now are actually different than the things people used to worry about before the Affordable Care Act. When most of our patients did not have insurance, we would hear a lot of anxiety and concern about, will I be able to come back and see you? Will I be able to afford the medications? Will I be able to see this specialist or get this procedure? And now, because most of our patients have insurance, which really for them is access to care, people have different concerns. They're focused on, how can I best take care of myself now that I know I have diabetes? Or can you tell me a little bit more about these medications? And sometimes when I take them, I have side effects. Or I have questions about the procedure I have scheduled next week. But they're actually different worries and different anxieties that people have. So we're happy about this shift.
Wow, yeah. Wow. I want to address a couple of things. Even though you're a doctor, and your lane, so to speak, the slice of life that you kind of are in charge of, you have a big responsibility. You're in charge of all these ambulatory centers for the county, and you'll lead the medical staff. But you've made some observations about how healthcare coverage affects our economy and our economic development. Let's talk a little more about that.
Yeah, so I think a lot of people don't realize how interconnected all of these pieces are. In other words, health insurance, health, economy, work. Before the Affordable Care Act, the most common reason that people would end up in poverty or become financially bankrupt, one of the most common reasons was because of unforeseen medical bills, especially for people without insurance. And a few years ago, we would have countless stories about people who had a good job before, had a good family, and then they ended up with an unforeseen car accident or medical condition that they were newly diagnosed with, and that gave them medical bills they couldn't afford and actually pushed them into bankruptcy. And as a result, their family, their work life, everything would fall apart. When people have health insurance, it provides a layer of protection and actually decreases the risk for bankruptcy and poverty. And why do we care about bankruptcy and poverty? Well, health is tied to all of these things. So if you have a good job, if you have a stable financial condition, if you have good housing, those things lead to better health. If you don't have a reliable source of income, if you're not financially stable, if your family is experiencing bankruptcy, all of those things will impact your health in a bad way.
So access to this insurance sounds like it sets up, what we call in policy circles a virtuous circle. It lays the groundwork for people. Well, first of all, it keeps people from falling down and going further into despair, and not just emotional despair, but literally their bodies are challenged with all this new stress, and families start to disintegrate under the all of the economic challenges that they're facing, especially if they're facing bankruptcy and tens of thousands of dollars of medical bills that they're just in despair about ever having to pay back.
Right.
So that begins to really, I think, wear on people. But if people are insured and they have some certainty that they're going to be able to get medical care, we see that they have some stability. They're able to move forward, and so there is a link between the health of a community and their ability to the economic future of a community.
Absolutely. So health insurance is, for most people, equivalent to access to care. And if you have access to care, that is a lifeline, or it's a protective mechanism against all kinds of stressors. So if we think of stressors in the broadest sense, so a stress could be, a strained relationship, it could be a strain at work, it could be losing a job, it could be experiencing sickness, it could be, experiencing crime in your neighborhood. Any of those things can be stressors. And health insurance can be one way that we can sort of protect or address those stressors. An example is when people are going through hard times, as you sort of alluded to earlier, they may experience more anxiety, stress, and depression. If you don't take care of that, that could actually impact your job performance. And if your job performance suffers enough, you may actually get fired. Mm-hmm. And then you lose your income, and then you lose your house. Mm-hmm. So all of these things are tied together. If people have good access to care, then as soon as they start experiencing a stressor, whether it's a new diagnosis of diabetes, or maybe a strained relationship at home, or some trouble at work, if they know that they can seek care and get support for their depression or their anxiety or their stress, on top of getting care for their diabetes, it's a way that it's a type of insurance or a way of elevating people through that stress. And sometimes it's just enough to keep people from falling and sort of spiraling downward.
Well, I've learned that people with diabetes, that depression often coincides, and it's not always necessarily. I mean, it's a depression that's associated physiologically with diabetes. The ups and downs of the blood sugar, I think the stress of like facing the lifestyle change, all these things, I think really challenged that person with diabetes, and I hadn't really understood just how something like diabetes, a condition, could also be linked to depression.
Yeah, this is something that's relatively new for all of us in terms of understanding, and now that it's very well accepted that diabetes and depression are closely tied together, and someone with diabetes actually has a higher chance for having depression, we've actually changed the way that we think about treating diabetes.
Oh, really? Wow.
So instead of just thinking about prescribing medications to control someone's blood pressure, we now also screen people for depression and stress and anxiety, because we know that if people have some undiagnosed or underlying depression or anxiety that we're not taking care of, it'll actually keep them from getting better. And even in our health system, we've added behavioral health specialists or clinical therapists to help with this piece of care.
So, doctor, this kind of leads me into a discussion about how wise the designers of the ACA. I mean, they didn't get it perfect, but I think one of the most important parts of the ACA was the 10 essential health benefits. And so we're talking about, it's just not enough to treat diabetes in isolation. You also have to treat the mental health.
Right.
You also have to look at preventative care. You have to look at access to adequate medications, and so there were 10 different essential health benefits, which the ACA said ensures, no matter who you were, where you were, you have to meet these 10 essential health benefits. You have to at least, it's a minimum. It's a
right.
consumer protection.
Right.
And go ahead. You want to respond?
So absolutely. I think the Affordable Care Act was not perfect, but it got a lot of things right, and sort of requiring insurers to cover all those pieces together actually creates a holistic approach to care. If you're missing one of those major pieces, like hospitalization or prescription drug benefits or being able to see a doctor in a clinic, then you have very inefficient care, or care that doesn't work very well.
So let's talk about this Senate bill that's been considered. There was a House bill that was passed that, in my chamber, I'm a member of the House of Representatives, where the Republican majority basically said they were going to allow states to weaken protections against pre-existing conditions being a reason why an insurance company could reject you. So the Senate said, okay, we hear you. In our law, we're going to say that pre-existing conditions are taken care of. And so, but as the law is written now, the Senate bill on its face, on the front end, says no pre-existing conditions can be used as a reason why you're denied coverage.
Right.
But let's talk about why that protection in the Senate bill is really, as it's written now, not all it seems to be.
Yeah, so on the surface, to say that we will ensure that pre-existing conditions will be covered sounds reassuring. But the problem is, in the Senate bill, states may have a chance to define either their own essential benefits or be able to waive having to meet the essential benefits. And so if states have an easier time to either define those essential benefits or waive them, what you could see is health insurance plans that say, we will cover you if you have diabetes, or we will cover you if you have cancer, but we cannot provide any prescription drug benefit. So if you imagine if you're a cancer patient and your medications cost $10,000 per month, and you'll get covered for your doctor's visits and your visits to the specialist, but you won't get covered for your monthly medications. What that means at a practical level is that for people with conditions, chronic conditions like cancer, like diabetes, probably their cost of care for themselves will go up.
So to shorten it all up, it's really discrimination against people with pre-existing conditions on the back end, a backdoor discrimination.
Right.
So on the surface, people are, some lawmakers are able to claim, well, we stopped this, but the fine print and the consequences of allowing states to evade what were like essential health benefits. So it's kind of you need a provision of the law that says no discrimination against people with pre-existing conditions, and you need to meet a certain level of coverage. And so the premise of the Senate bill is this idea that we're going to make coverage cheaper, but what they're not telling you is that they're thinking of ways to make that coverage less meaningful, to the point where it's, for a lot of people, it really won't matter that they're covered.
Right.
They're paying money. And so the whole idea of this bill was to protect consumers and patients from very confusing policies out there. And so what we have now are even people who are covered by Medicaid or Medi-Cal. They have 10 essential health benefit protections, as well as people who have, even if they get their insurance from an employer, there has to be a certain level of insurance, certain level of coverage that those people are guaranteed as well, right? So it's really not as if. So you were doing. I mean, you have some ideas about how it is. People who think that they have health coverage from their employer. There's a connection between everybody else being covered and their insurance being meaningful too. Right. So let's talk about that.
So, as we talk about healthcare reform, a lot of people think we're talking only about the Medi-Cal or the Medicaid population. In other words, people who tend to have lower incomes, who may have recently gotten insurance. But actually, all of this discussion about healthcare reform affects everybody. So even if you're somebody with private insurance from a big company and you've had that for 10 or 15 years, this new healthcare reform bill that's being proposed would likely affect your coverage as well. It could mean that if you're older, or if you have diabetes, or if you have a behavioral health condition, or if you're pregnant, that your costs will actually go up. And so there's sort of an indirect impact, because these rules about insurance affect not only Medi-Cal coverage, but everybody's coverage for insurance.
Wow. Well, let's kind of get that more, maybe a couple of examples of what could happen. I mean, one thing that I think about is in terms of the 10 essential health benefits. That's a good thing for people with employers, right? They know that they're going to get comprehensive coverage, that no insurance company can do them less. We have now, under the current law, no insurance company can say there's an annual cap on how much you're paid out. So if you have cancer and your medicine costs you $10,000 a month, and the insurance company says, well, we're only responsible for 80,000 of it, 8 months worth. The rest is on you. And so that's, for a lot of families, $40,000 worth of expense is huge. And then the other thing that used to happen is, well, I'll pay the 40,000, but I can do at least 80,000 next year. Well, the insurance company would often say, well, there's a lifetime cap, right? So we'll put a cap on how much we have to pay out. The Affordable Care Act said you can't do that. That's what it means to have decent insurance, is that you cannot be capped out either. So that protection really is important for those people, the 80% of our population that gets insurance through private employers.
So some people don't realize that the reason we have the 10 essential benefits in the Affordable Care Act, the reason we have so many protections and requirements, is actually to address problems that we saw before the Affordable Care Act. And we actually saw all those problems that we've been describing right now. People who would discover that they didn't have enough coverage, or they hit a lifetime cap, and and that they sort of owed the rest of the bill, or that they purchased insurance, but it actually didn't get them what they thought it would. So you can just imagine how much shock and confusion there would be if, you know, people are buying insurance in the future and then discover that, well, it covers your doctor's visit, but it doesn't cover an emergency room visit. It covers your, you know, maybe it covers a hospitalization, but it doesn't cover your medications after you go out of the hospital.
So it's kind of like, I used an example before about kind of like how sometimes I'm tempted to buy travel, and sometimes traveler's insurance makes sense. You know, you got a cruise and you want to make sure your flight, you want to insure your flight. But I was, you know, often, you know, my staff thought, you know, maybe if you don't make this, if your meeting is goes over and you can't make your flight, we should probably insure your flight. But then we find out in the fine print that that's not something that in travel insurance that you're insured for. There's a lot of fine print in the contract, and the Affordable Health Care Act was really designed to try and minimize the misunderstandings about what you were covered for or not covered for. Now, look, there's another important thing I wanted to make sure we got to, which is it had to do with making sure that people not only were covered, but they also had meaningful insurance. I know what it was. Here, I'm trying to remember what it is. So, you know, we've used this example of the emergency room, and how the emergency room would be filled with people who, some of them were appropriately there, but a lot of inappropriate use of the emergency room. A lot of uncompensated care would be given by the county or other hospitals because you have to take in these patients. And I've heard some people say, well, stop talking about that. Affordable Care Act didn't really solve the emergency room problem. Your emergency room is still filled with people. And the hospitals are still charging $20 for Tylenol. So let's kind of unpack some of that a little bit.
So the emergency room concept is confusing when we think about healthcare reform. Definitely what we see when people have health insurance is that if they have a true emergency, they are more likely to go to the emergency room. If someone doesn't have health insurance and they have an emergency, they may or may not go to the emergency room. So when there are more people with insurance, we see more people going for appropriate reasons to the emergency room. But the flip side is that before the Affordable Care Act, before we had this increase of insured people throughout our county, we had a very large number of uninsured people who would go to the emergency room for any type of their care, including care that would have been most appropriate for them to get in a clinic setting. When that happens, that clogs up the emergency room for everybody else, including those people with private insurance who may have a true emergency. When those uninsured people now have health insurance for their colds or coughs or refills for their diabetes medications or headaches, now it is easy for them to get into a clinic to get care. So they are actually seeking care through appropriate routes and not going to emergency rooms as much for inappropriate things.
Wow. So and the big difference also now is that probably a lot of the people who are going to emergency rooms now, you're saying that it's more likely than not it's appropriate that they are going there. They're not going there for small little things. And it's been a learning curve because some folks didn't have insurance before, right, and they had to learn not to go to the emergency room and come to a clinic like this that we're in now. But that they also that the county and other hospitals are compensated for the care that they do give.
Right.
Is that right?
So if your patient is uninsured and they come to the emergency room and they have a large bill, that patient will not be able to pay that bill, and the emergency room will have to make it up somehow. If that patient has insurance, then we would expect to get paid by that health insurance plan. So the more people you have insured, the better you're able to fund or pay for the appropriate care in the emergency room.
So I want to take care of this little matter issue out there. So that encouraged a lot of hospitals to charge a lot of money for a Tylenol. Typically, the person they would charge is the person who had no insurance, because the insurers would actually negotiate all of these sorts of charges with the providers. So insurance companies, because they were providing lots of revenue to the hospital, would say, you're not going to charge me $20 for that Tylenol. If we're going to pay you reasonable things. And your doctors, we're going to pay so much for this procedure, that procedure. So really, it was the uninsured population that would get charged if you didn't have any insurance. That's who would get charged those so-called retail sort of charges or rates. And but it's good that some people are looking at their bills and going, they're questioning how much. But often you'll see what the hospital wants to charge, but what the insurance company is actually contracted to pay.
Right.
So I want to just keep that straight for some of our constituents out there. But let's make no mistake about it. That we're starting to come out of tough economic times. We have a lot of people who don't make as much money as they would like to make. In fact, that's why we have so many people qualifying for Medi-Cal. They make $16,000 or less if they're a single person, and that could be working full time. And still, that hourly rate doesn't bring them above 133% of the poverty line. But it makes no sense to me that we allow people to have their health deteriorate as an economic strategy to get ahead. It seems to me we've got to maintain people's health, keep them in good health, good mental health, good physical health. That is the underlying basis of a good workforce.
Right. You could actually have the opposite effect on your economy. So you may think that you're saving some money on the short term by pulling dollars out of Medi-Cal and Medicaid. But when you do that, and then people actually have sort of less buffer and less protection for their health, especially in times of need, then actually that puts the entire community at risk. Health in a way is contagious. So when you have many families that are suffering from stress or depression or health conditions that are impacting their ability to work, be productive citizens, take care of their communities, this actually has a ripple effect on the entire community and economy. When people are in good health, they're actually able to work better, be better parents, be better spouses, be better employees. That actually supports a thriving economy. And the healthier the people are around you, actually the healthier that tends to make us as well.
Well, this is, so we're talking about how the Affordable Care Act has been able to help meet the needs here of the real medical needs of people, health needs of people here in our area. And I think the final sort of thought that I want to start to explore, and then we'll have to kind of bring a wrap to this, is, Dr. Gilbert mentioned to me about the $1 billion that comes into the two-county area. The fact that you have more people insured, I mean, we're talking like you get 70% of the patients were Medi-Cal. I mean, 1/4 of those people before the Affordable Care Act. Now you've more than tripled the number of people who are covered. It's brought a lot more certainty and financial stability to how you can run these clinics. And you told me that it's enabled you to plan to hire more physicians. You can pay physicians at competitive prices so that we can actually get doctors and specialists to actually locate here in Illinois. Is that right?
Right. Because more people have health insurance, it's actually improved financial support for our clinics, and that translates into better and more service for our patients and community. So that means that we can actually hire more doctors or nurses, that we can expand clinics that are too small to meet a community's needs. It means that we can add clinical therapists and behavioral health specialists to our clinics to serve patients who may also have depression along with their diabetes, so we can take care of them at the same place. It allows us to do innovative things. We provide virtual telephone visits for patients who have difficulty getting into our clinics physically, and all of this type of support through the insured patients where we get payment allows us to basically serve our community in a better way.
Well, Doctor, as you know, I've been trying to do a lot of work trying to get more medical residencies at University of California, Riverside, try to grow the community of physicians and doctors. We have a shortage as per our population. And of course, this tells me that this is far from just, this act was far from just helping people of low income. For our region, our future economic development, if we're a community that has a shortage of doctors, we're an unattractive place for people to locate, right? So it is all part of an economic development effort that we have to have. I mean, in healthcare, education, these are very fundamental things, and we need to build that infrastructure. And to lose, that $1 billion that's coming into our economy to support our healthcare infrastructure, that would really be a step back. We're just now coming out of a recession. Be a real step backward for us, wouldn't it?
Yeah, it absolutely would. More dollars that come in through health insurance or health insured lives for our community literally translates into more jobs, more people taking care of the community, whether that's medical assistants, more nurses, more physicians, more people working in a laboratory as a technician, more people working at a hospital. And every additional job that we have in our community and county also has that positive ripple effect, because then maybe now you have someone who can support their family and they have health insurance for their own family, and it also creates a thriving economy that can attract great professionals from other regions of the state and from out of state to come join us in Riverside County and turn this into a thriving knowledge economy.
Well, we have all the elements for a knowledge economy. We have a great University of California. We have La Sierra University. We have Cal Baptist University, Riverside Community College. We have the basis for a great knowledge economy. I mean, God forbid we start worrying about severely escalating home prices. And housing's an issue out there, but what a problem to have down the road. But we have the basis for, I think, a very thriving economy, to be optimistic about our future. But let me just end on this. Doctor, thank you for the time you spent with me. Thank you for taking your education and your medical education and deciding to make Riverside County your home and part of your career, and to work with the families that need you here. We need more doctors like you, and the Affordable Care Act is a very important. Look, there's no solution in this Senate bill for the workforce, the medical workforce issues that we have, and it would hurt our region terribly if that bill replaced what we have now. The Affordable Care Act certainly is not perfect. I wish the conversation could turn on how we improve it, but right now I think it's really important for us to really point out to the people here why the Senate bill is such a threat to our people here, our community. So thank you so much for joining me.
Thank you, Congressman.
Thank you. Thank you.